And we're just going to let participants, as they're getting off of work or maybe jumping onto their phone, into their car on their way home, whatever is convenient to them. If you have your phone out or you're on your desktop, you can see me here, Dr. Sapienza in the maroon, Dr. Edie Hapner, and Dr. Aaron Ziegler. If you want to give a wave, they're getting geared up to speak with you. That's right. Getting our exercise already ready. Folks are saying hi. So we're just waiting another minute or so here before we start. It's about 5:28. And remember, I will do a little bit of housekeeping in the beginning. We'll do some introductions and then we'll go right to our scheduled talk. So welcome everybody. I'm Dr. Chris Sapienza. We're just waiting for people to join into the Zoom room. I'll be moderating the session. I'm watching the chat from Meg, who's already, yep, you can get a certificate of attendance from Gail Wiley, EMST150.com. You're right, it is going to be awesome, and they haven't even started talking. So 5:29. I'm waiting for the number 100 here. We've got 99 participants. There's 100. We've got a big crowd. Luckily, we're all. Thanks so much, Clara. Good to have you here too. We do want folks to use the chat. We'll be asking some questions at the end. Kindly, Dr. Hapner and Dr. Ziegler have left us time for questions. We're at 110 participants so far. Just as a reminder, I'm Dr. Chris Sapienza in the maroon, Dr. Edie Hapner, you can see her name, and Dr. Aaron Ziegler. So we just have another minute or so and I'll kick it off. I always like to let everybody have time to get into the room. So we're right at the 5:30 mark. And so for those of you who are joining in, it's like a lottery ticket here. It just keeps on clicking up. We're at 122 participants, 125. I'm Dr. Chris Sapienza. I hold the role of provost at Jacksonville University. And oftentimes you'll find me moderating such great sessions as this through a company called Aspire Products, www.emst150.com. I really enjoy these because these sessions are free and we bring in great talent to talk to us about things like voice, airway, swallow, breathing, clinical care. And we are just so fortunate to have Dr. Edie Hapner and Dr. Aaron Ziegler with us this evening. Briefly, these two have biographical sketches that are pages long. But Dr. Hapner and I have known each other for a long time. She's the George W. Barber Foundation professor, co-director of the University of Alabama Voice Center, director of the otolaryngology, speech and hearing services. Her specialty areas are voice, upper airway. She was the co-developer along with Dr. Ziegler on PhoRTE, which you'll hear about tonight, Ph.D. from Vanderbilt and a fellow of ASHA, and the list goes on and on. Well-published scholar in our field. Dr. Aaron Ziegler, also Ph.D., University of Pittsburgh, went on to do his CFY at Emory Voice Center, and then back to Pittsburgh to do some clinical care. Got the entrepreneurial bug. As you can see behind him, he's developed his own independent group called the Wellness Group for voice, speech, and swallowing, travels all over the world. He was just talking about the fact that he's going to be heading to Ghana tomorrow to volunteer to educate students in voice. And so, Aaron, we're so glad that you're here and also can speak to us about PhoRTE. So with 154 participants right now, Dr. Hapner and Dr. Ziegler, I'm going to ask you, Dr. Hapner, if you can share your screen.
Yes.
And we'll get that up and rolling. Folks, put your questions in the chat. I will watch them. I'm going to turn off my video during the presentation and enjoy. Dr. Hapner, Dr. Ziegler, thank you again for being here.
Well, thank you, Dr. Sapienza, and to the Aspire Respiratory Products. This is really exciting for us. Erin and I love to talk about PhoRTE, but we also love to talk about anything to do with respiration. It's been quite a journey for us learning about respiration and its impact on voice over the past 13 years now, Erin. And so we're going to just talk to you a little bit about what we know today. Hopefully we'll know a little bit more tomorrow, but let me start by saying that these are our disclosures, and the important thing about these disclosures are Erin and I are the co-owners and co-developers of PhoRTE Voice Therapy. And so we are going to be talking about PhoRTE, but we're going to be talking an awful lot about respiration tonight. So let's just go ahead. We thought that it might really behoove us to start by talking about what is PhoRTE. Well, first of all, PhoRTE is a systematic set of exercises. It is based on 12 years of theory and of testing. This is not something new we came up with, and I'm going to go through the history a little bit with all of you. But 12 years of working together on the idea that high-intensity vocal exercise that coordinates respiration and phonation has a role in the treatment of presbyphonia. PhoRTE is dynamic, and as we talk about it over the next few minutes, you'll understand that PhoRTE is not the same today as it was when we first published on it in 2014. And it's not even the same as it was in 2018. So we learn every day. We learn from the people that we train. We learn from our patients, and we integrate that information into the work of PhoRTE. And I think Erin will talk a little bit about some of those changes, but just very briefly, I do want to tell you, because I don't think we said this, Erin, we are actually working on a study right now that we hope to get out in the literature in 2023, where we taught people with a lot of expertise in voice PhoRTE. We had them use it for a couple of months, and then we literally sat and got their input and have made changes to PhoRTE because of the information that they gave us. So it is also peer-reviewed. PhoRTE is based on the principles of exercise, and I'm going to keep harping on the word exercise because I don't think everything we do is exercise, but PhoRTE is. It is individualized like the body physical exercise is. It is specific to the muscle and the systems that we are trying to train. And it is based on the principle of overload. So the only way that your body can adapt and get, I don't like to use the word strong because we don't use the word strong, but to have more endurance and less effort is to keep giving it greater and greater loads and expect it to, come up to the program and to get stronger. It's called adaptation of exercise. PhoRTE is individualized, and it really is, and that's what your evaluation is, and your recalibration every couple of weeks. So it's designed specific to the patient's respiratory and phonatory status in that moment of testing. So what isn't PhoRTE? Whoops, let's see if I can get the next slide to come up. PhoRTE is not a cookbook. Right? It's a method that celebrates clinicians' expertise and insight. So in other words, we have a set of 5 exercises, but what you understand about your patients and how to mold and shape their behavior is really the cornerstone of PhoRTE. It's individualized, as I said, but what's important to know is that PhoRTE will look very different if a patient is frail than a patient is able-bodied. It's not tested on populations other than presbyphonia. People ask us about that all the time, but Erin and I are pretty rigid about this and say that we have only done the testing on people with presbyphonia, so that's where we know the evidence is. It is not repackaged LSVT. And as a matter of fact, if you watch the way PhoRTE is done and you watch the way LSVT is done, it's very different. And FYI, we were around before Speak Out. Now here's where we're going to talk about exercise a second. PhoRTE is not resonance therapy. It is not recalibration. It is not for doing less and addressing extra muscle tension. It's really built, as I said, on overload and adaptation of the muscle through exercise. And it actually really, another cornerstone is that PhoRTE is not just sustained vowel, just a sustained ooh or a sustained oh, but it actually builds on motor learning theory and talks about carryover into phrase length and conversation. So let's briefly talk about the history of PhoRTE and what we've learned, especially as it relates to respiration. So back in, this is 2013, when it was published online ahead of print, we did a study of something we called loud voice therapy. And it was the first prospective randomized controlled trial in the treatment of presbyphonia. And we took older adults, people 65 years and older, who were diagnosed with presbylaryngitis by the otolaryngologist or the laryngologist, and presbyphonia by the speech pathologist. And we randomized them to either vocal function exercises or something that we called loud voice therapy at the time, which was the first iteration of PhoRTE. And we also randomized them to a no treatment group. We gave them 4 weeks of equivalent therapy in home practice. And what did we find? Well, we found that loud voice therapy and vocal function exercises, the people in those groups, exhibited significant improvement in their voice quality of life, where the control group did not. We found that the people who had loud voice therapy actually demonstrated a significant reduction in vocal effort, where the control group and the vocal function exercises did not. And lastly, we found that people that did loud voice therapy, the first iteration of PhoRTE, actually had higher treatment satisfaction scores. So then we were lucky enough to have some amazing research done by some of our colleagues, and I'm going to go through a few of the studies here with you. Now, this study, published in 2020 by the group at the time in South Carolina, did a systematic review to determine the state of evidence for using respiratory exercises to improve voice and respiratory outcomes. Now, I say the reason this is so fascinating to us is that we believe that PhoRTE capitalizes on the relationship, on the dance between respiration and phonation. So our colleagues actually found 650 articles that looked at respiration and voice, but 23 articles that met criteria. And they actually studied 9 different types of respiratory exercise. Yes, there was IMST and there was EMST, but there was also things called easy breathing and other things like abdominal, diaphragmatic breath support. And they found that in 12 of the 23 articles, the researchers found that working on respiration actually made changes in voice. But that means that 11 articles found that changes in respiration didn't always translate to changes in voice. And they said that perhaps voice improvement as a result of respiratory exercise was patient-specific. So then the same group of researchers went on to look at how variations in respiratory function impacted the voices of people with presbyphonia. And they studied 21 adults with presbyphonia who went through a comprehensive respiratory and laryngeal assessment. And they found that respiratory function can indeed impact voice. And yes, it can impact voice physiologically through reduced maximum inspiratory pressure, maximum expiratory pressure, or that ratio of forced expiratory volume in 1 second over forced vital capacity, a measure that often we look at in both asthma and inspiratory laryngeal obstruction. But interestingly enough, they also found that it can impact the voice indirectly. So if there is reduced respiratory function overall, it results in more shortness of breath. And if you add a glottal insufficiency, as often is found in presbyphonia, to that, you have even more complaints of shortness of breath. And I bet a lot of you on this call can say, yeah, one of the common complaints of my presbyphonics is that I feel winded. I feel short of breath. And we always are sure to say, now, is that during talking do you feel short of breath, or is that during exercise or just sitting here quietly? And happily, they suggested that respiratory screening should accompany all voice evals and certainly precede voice therapy. And the reason Erin and I were so happy to see the results of this study is that we had actually come across a study by Vaca et al. In 2015 that really looked at both respiratory and laryngeal profiles of people with presbyphonia. And so they actually did their study in Spain, and they had 105 people with pathologic presbyphonia. So what does that mean? In Spain, they actually have a bit of a diagnostic paradigm for that. And briefly, someone who comes in and has complaints of voice changes as a result of aging, in a male, if they're able to sustain phonation for less than 15 seconds, and in a female for less than 12 seconds, they're considered to have kind of a pathologic presbyphonia. So Vaca and colleagues took 105 people who came in with those complaints. Forgive me, I'm trying to move this out of the way. And they found that 19 people, or 18% of that 105, came in, and when they did a laryngeal exam and a very comprehensive respiratory exam with spirometry, 18% of the group had no signs of presbyphonia in the larynx or in the respiratory mechanism. They found that 21% of the people in this study had that vocal fold gap, that appearance that we all assume is the appearance of presbyphonia, kind of a glottal gap, prominent vocal processes, but normal spirometry. The largest group, 37%, or 39 of the 105 people, had complete glottal closure on video stroboscopy, but altered spirometry. So they came in with complaints of presbyphonia. They met the criteria for a pathologic presbyphonia, but they had normal vocal fold closure, altered respiration. And they also commented on that 24% of the group had both a vocal fold gap and altered spirometry, and those people actually demonstrated the most impaired voice quality. So we were part of a study with a great group from Emory University and from the University of Pittsburgh that was also a prospective randomized controlled single-blinded non-inferiority study of phonation resistance training exercises, or PhoRTE, with and without EMST. And this was a non-inferiority study. So in other words, we were just trying to determine if any of our cohorts, and I'll tell you those in a minute, had inferior results to the other. So one of our cohorts was PhoRTE plus EMST, and the other cohort was PhoRTE alone. We enrolled 26 people, but then COVID hit, so 16 completed the study. And what we found was the group that did PhoRTE plus EMST actually both groups had improved VHI-10 and improved aging voice index scores. And the PhoRTE plus EMST group had improved maximum expiratory pressure. But the most impressive finding for us was that PhoRTE plus PhoRTE alone was not inferior to PhoRTE plus EMST. In other words, you got similar results. So going back to that great group originally in South Carolina, they wanted to look at a similar study where they did specific voice therapy exercises and compared both IMST and EMST. And what they found in 12 adults was that the presbyphonics who did inspiratory muscle strength training plus vocal function exercises had improved voice quality and connected speech after 4 weeks of therapy. And they believed that they had improved voice quality and they had reduced subglottal pressure, so it took less effort to make voice. The group that did EMST plus vocal function exercises once again had that improved maximum expiratory pressures and strengths, and they had improved smooth capsular peak prominence measures, but they had limited improvements in self-perceived voice quality of life and in vocal effort or subglottal pressures. And the group that did vocal function exercises alone actually only had improved voice quality on sustained vowels. Interestingly enough, they had a decreased amount of vocal fold bowing. So the authors concluded that IMST plus vocal function exercises they used may lead to the greatest benefits in the treatment of presbyphonia. So I'm going to pass this on now to my colleague, Dr. Ziegler, to start talking real specifics.
You've heard a lot of great information about the efficacy of various respiratory approaches that have been tried in the literature. Well, what we haven't heard yet is how do people get to us as speech language pathologists? And a recent study published in 2021 in the Journal of Voice looked at treatment decision making among laryngologists, so one of our referral sources. And among the 89 laryngologists who responded, the researchers found that about 60% of laryngologists, of those 89 laryngologists, recommended voice therapy as a first line of treatment. Now, that's great that we have so much support from our laryngology colleagues that they are referring patients to us, but not every patient necessarily will respond well to voice therapy as the first treatment. There is a very important consideration, and that is glottal gap size and how that impacts the voice. So our laryngology colleagues are considering glottal gap size. 87% of them use that information, how large the gap is and how it impacts vibration, to drive decision-making for an augmentation procedure. So a surgical procedure to plump up the vocal folds bilaterally in order to improve their closure pattern. All right. And so not surprising that laryngologists are thinking about glottal gap, because the research literature shows that gap matters in outcomes for presbyphonia. So the group from in Texas with Dr. Mao and colleagues looked at, well, this was actually in 2010. This was a retrospective review, and they found that glottal gap was one of the main predictors in patients' outcomes with regard to treatment for presbyphonia. So when the gap size was larger, patients did poorer in voice therapy. And so it's important that as patients are referred to your clinical practice for voice therapy, you are making some decisions about treatment and factoring in gap size in your equation about who would benefit from your services first. And so Dr. Hapner and I next have come up with a treatment framework for presbyphonia. And we've thought about 4 main options for treating presbyphonia. One, which includes just watching and waiting. And so the patient in this case knows that their larynx doesn't have any sinister lesions growing. There's no malignancies there. They are okay with the process that they're experiencing. They consider it natural, and they really don't want to engage in the therapy process. Maybe they have other medical considerations that they have to attend to. And so they're willing to just wait and see what happens. Now, in that situation, what we know is that this process continues to evolve. And so per people's voices and likely their vocal mechanism will continue to deteriorate over time. So the patient should expect some worsening in voice over time if they watch and wait. And then there's what can they do about it if they want to intervene and go through some sort of treatment. Well, then there's really addressing the vocal folds with a surgical procedure, and that would be with our laryngology colleagues. And there is a procedure that is temporary, and then there is a more permanent solution. The augmentation, bilateral vocal fold augmentation, is an option for people who are maybe not stimulable for voice therapy. Their gap size is too large. Maybe they have also a concomitant dysphagia, and we want to make sure that our patients with dysphagia are getting that addressed early on, because we know that healthy lungs are going to support healthy voicing. And so if they're dealing with aspiration pneumonia or lung congestion because of dysphagia, or if their larynx is always on guard with coughing and throat clearing and expectorating material that's entering the upper airway, they might not be available for producing voice. So the other reason may be that a patient may be frail. So Dr. Hapner and I consider a patient's frailty. How capable is their body physically to engage in therapy? And patients who are quite frail, they're likely not able to participate in a behavioral approach. They won't be able to, at least immediately, until they've built up better physical fitness, to generate the subglottal pressures that they'll need to voice. So in that case, that type of patient would be perhaps a candidate for a bilateral vocal fold augmentation procedure. It's outpatient, typically awake, and it's pretty quick as well. It's a nice solution for somebody with a gap size that's large and isn't stimulable. And then there's the more permanent solution where the laryngologist would do a bilateral medialization thyroplasty. So they're implanting a silastic block on both sides, in moving, sort of shoving the muscle and the vocal fold over, so that there's less of a gap and there's more of a straight vocal fold edge versus some concavity. And this may be beneficial for somebody who needs a permanent solution. So with the augmentation procedure, that is a temporary solution because the material tends to be resorbed by the body. And so usually they will need either another augmentation or they may elect for a permanent solution. This may be an option for somebody with loss of bulk versus has a tone issue where they have floppier vocal folds, but they're still getting good closure. They may not be such a good candidate for the thyroplasty, but the patient who has lost a lot of bulk to their vocal fold, maybe lamina propria, maybe muscle atrophy, or maybe a combination. We don't know when we look visually with the scope what layers of the vocal fold are not as bulky, but we see this gap that lets us know that there has been tissue loss. And so in that patient, they may be a candidate for thyroplasty. And then some patients just can't tolerate an in-office procedure, and they are not a candidate then for an augmentation and may benefit from the thyroplasty, which would be done in an operating room. And then there is voice therapy. And now we, at PhoRTE, Dr. Hapner and I, we believe voice therapy is a part of the care process for probably most and maybe all patients with presbyophonia who elect to do something. And we believe that voice therapy is appropriate when somebody is stimulable, when their deficits are more respiratory than laryngeal, right? So if they have a large glottal gap, we're not going to start with PhoRTE or other voice therapy approaches. We're going to send them to our laryngology colleague. And for patients who are more resilient, they're maybe mildly frail or vulnerable of frailty, but they're not quite extreme frailty yet. So they have more resiliency. And then we would recommend voice therapy in such cases. So that's our framework that we use to think about making decisions for who should engage in voice therapy. All right. But what voice therapy then do we engage in, or voice therapies do we engage in when they are a candidate for voice therapy? And Dr. Hapner and I, we think about voice therapy in sort of classes. So more exercise-based approaches where they're really targeting adaptations to the muscle. Then there's recalibration-based therapies that are really about optimizing function. And then desensitization-based therapies where we're trying to relax and calm the upper airway. Well, for our presbyophonia patients, we really think about, well, in some cases, they come in with both presbyophonia and a chronic cough. Sometimes the chronic cough is a result of a speaking technique issue. But when we're just looking at presbyophonia alone, we're really looking at either an exercise-based approach or a recalibration-based approach. And you can see under the exercise-based approaches, we have, for instance, PhoRTE, vocal function exercises are theoretically exercise-based, IMST, EMST, LSVT, or speak out, any sort of exuberant approach where you're really loading the system is likely making adaptations to the muscle. Now we can talk about what those adaptations may be, but there's likely neuromuscular adaptations happening as a result of these exercise-based approaches. And then in the recalibration-based approaches, you have things like approaches like resonant voice therapy, flow phonation, semi-occluded vocal tract exercises, perhaps conversation training therapy, where you're really working on coordination of the subsystems to help to relieve laryngeal hyperfunction and have a more calibrated, more efficient sound. All right. So when we approach for presbyophonia, we're approaching it from the standpoint of that, yes, it is a condition that happens as a result of time, but not time alone. We believe that sarcopenia, a process that happens in our bodies, throughout our bodies, where we have a loss of muscle mass and reduced strength or function, we believe that sarcopenia plays a role in the development of presbyophonia. And likewise, it's well documented that skeletal muscle atrophy is a part of this process and due to physical inactivity. So when you unload the muscle, when you don't give it enough load, you don't use it enough, it atrophies. And that's what we see in the skeletal muscles of our limbs and arms. We don't know in terms of the development of presbyophonia whether or not physical activity or inactivity has a role, but we believe that there is likely a relationship. And why do we believe that? Well, there are some really great studies I'm going to tell you about with singers here next. So in singers, we actually see this wonderful effect, this use it or lose it effect in our older singers. There's been a number of studies published on older singers versus younger speakers. And what they find overall is that people who sing, who use their voice in an exuberant way, singing is very much an exuberant voicing behavior. People who sing, they tend to be perceived younger than older non-singers. So their peers, people who are of like age, they sound younger than their older peers who are non-singers. And older singers actually sound closer in age to younger speakers. So using their voice helps them maintain their voice for longer. They have greater vocal intensities in general. They have higher speaking fundamental frequencies in general, and they have less noise in the signal of the vocal signal. So it's a clearer sound that they're producing. So it says something about the body and the vocal mechanism and how it responds to using it in an exuberant way. Now, certainly we have some singers who use it too exuberantly, right? And they develop nodules, polyps, cysts. And in those cases, we're talking about mucosal stress, biomechanical stress that leads to mucosal changes from unhealthy voicing and impact stress. But when you use the voice healthily over the lifetime, then there's a way to maintain it into senescence. All right. So what are some of the considerations we're thinking about in programming voice therapy for presbyphonia? How intense does the therapy need to be, and how much of it do they need to do it twice a day, 6 times a week, or is it a less severe problem with milder deficits and they can go with a less intense approach, maybe even not as much practice? So dosage, type of fitness, what are we targeting when we are doing voice therapy that involves respiratory approaches? Are we building muscular strength? Are we building muscular endurance? Are we improving cardiorespiratory endurance, aerobic endurance? Likely, we're probably involving all of that in different levels. When we're talking about voicing and exhalation, voicing doesn't really have high subglottal pressure requirements. So it doesn't really require a lot of force and in force generation to create high lung pressures. It's not like cough, which does. And so when we're training voice production, we're probably working on more muscular endurance, being able to maintain a submaximal force over time. However, inhalation is a very quick ballistic action that requires engagement of the diaphragm to really enlarge the lung cavity and draw in air in a very short amount of time. That likely is going to be really requiring power and strong muscular involvement in a short period of time. And so there's what type of fitness are you training? And lastly, which phase of ventilation? Are you going to train exhalation, inhalation, both, neither? And without voice or with voice. So are you going to do it in a therapy approach that doesn't use voice, where you're just training the blowing of air, the movement of air, ventilation? Or are you going to couple it with voice? That's more of a coordinated process, much like a manual car where you're having to navigate the clutch and the accelerator at the same time. These are the 3 main ideas that we think about with regards to programming. And PhoRTE really focuses on high dosage with high expiratory pressure. So really engaging the respiratory system more fully in an exuberant way. And then coupling that with improved phonatory adduction. So getting better closure, better vocal fold vibration. If we have greater subglottal pressures, then what we get is the vocal folds being blown apart more, and they actually get a little bit more recoil. And that's going to be a great thing for somebody with a gap. It will help them get a little better closure. And then we know that this is a nonlinear system. It's interactive. So what happens above the vocal folds is going to affect how they vibrate. So with more space in the vocal tract, a more oral, megaphone oral resonance, we're going to hopefully encourage more closure. Remember, it's the complete opposite of a semi-occluded vocal tract, which creates more of a gap when we have high impact stress. So with an open vocal tract, nonlinear dynamics says that we should get tighter closure at the level of the glottis. And with this, these 3 goals for the physiologic treatment of presbyphonia, we're hoping that we can address complaints of loudness and improving their vocal intensity, decrease any vocal effort that they're experiencing and improve their voice quality. And as Edie, Dr. Hapner told you, our studies are demonstrating some of those improvements with some of our early data. So we see PhoRTE on a continuum, a dose continuum from low dose to high dose. And this is just a framework, a conceptual framework about thinking in thinking about different voice therapy approaches and where they might fall in a dosage continuum, with things like flow phonation and resonant voice therapy, where we're having people do less, usually used for people who are overdoers. We might consider that a low dose type voice therapy, whereas something like LSVT or respiratory muscle strength training, where you're working people out at either a really high vocal intensity or at 75% of their maximal inspiratory or expiratory pressure, those are really exuberant, high dosage type approaches. And so the answer really is that you have to know what you're dealing with. And that's where our assessments are so important. So, I think we're returning to the days of Hickson and Hoyt, where we really paid attention to the respiratory system and its contribution to voice. I think during the 90s, as we got really great technology to image the vocal folds, we got a little bit laryngocentric, but we're zooming back out, and we're gonna, I think, start to embrace some of the more respiratory assessment options that we have in getting a better understanding of the full capability of this mechanism, not just at the level of the larynx, but also at as the respiratory system contributes to phonation. And we're happy to take some questions now here.
Well, thank you both, Dr. Ziegler and Dr. Hapner, as we're getting our videos back online. You do have questions, and that was outstanding. You spoke to 210 participants this evening, so thank you for that great effect size. I think there's a lot of interest, obviously, in your technique. First question that a lot of people are wanting to know is, where can they get more of you? What courses are coming up? That we both texted in the chat. This is not a type of therapy where you need to have a certification, where you need to necessarily be, paying for certifications to be a user. I think the three of us, as researchers in the field, have always believed that if folks can just understand the physiology of what the larynx does and what the respiratory system does, then you can really understand whether you want to use a PhoRTE or an RMT or any of the other types of therapies that are out there. So first question, where else can folks either find you virtually or on a campus or at a health center?
Yeah. Okay. Erin's looking at me. So we're really excited that hopefully right after the first of the year, we're going to have on the PhoRTE website the opportunity for asynchronous learning. And so you don't have to take off your Saturdays or your Sundays or whatever, and you can learn at your own pace. So we are putting together right now the final touches on the asynchronous course for people now. But I just have to say this, Chris, because it's so true. We like you believe that we study things and we learn about them and we want to share them with our colleagues, and so they can thrive and enjoy therapy and get people better. But the one thing that Erin and I know about PhoRTE is that the form is the important piece. And so some of the things that happen when people read and then try and do is they write us and they say, oh, my patient says that it makes them cough or it hurts their throat. And, our first answer is that when you have proper form in producing the stimuli, that doesn't happen. At least it hasn't been a frequent occurrence for us. And so that's why we like to encourage people to come to a course, because we spend a lot of time practicing together.
That's right. And I think people are always concerned, Edie and Erin, about side effects. And I think form is definitely one of them. They have to be, solid users. So in the asynchronous it sounds like then there's plenty of video and things that they'll be able to watch in order to, which is just great because you can replay if you need to. And for the folks on the line tonight, we will post this presentation so you can look at it a few times before we take it down off of the EMST 150 site. Erin, folks were asking about outcomes, and I heard you talk about maybe some acronyms not everybody's familiar with, but can you talk to us a little bit about quality of life scales? And, if I don't have all the tools in the toolbox at the speech pathology clinic, what do you think is the best way, in your opinion, to determine whether PhoRTE is working?
A great question. I think that the most important piece of the puzzle is the patient's perception. Are they feeling better about their voice? I think that measures that are good for that. We have found the Aging Voice Index to be a phenomenal measure. It's very specific to this population, but we've also found that there are we capture treatment effects with regards to patient perception in the VHI-10. In fact, also in the VRQOL, all three of those measures, which is kind of nice for us in terms of thinking about whether or not we're actually capturing a response. It doesn't matter which patient-reported outcome measure you use, there is a perceived response to our treatment. So you could use any of those three. I'd also say that we're seeing some really nice, our studies haven't been powered for instrumental outcome measures. So they've been powered for quality of life measures, our patient-reported outcomes. But what's really nice is that in our two studies to date, our randomized control trials, we have seen some nice effects of treatment with regards to vocal intensity, with regards to cepstral peak prominence, which is a nice indicator of voice quality, very sensitive to breathiness, which in presbyophonia is an issue, right? As we have more of a gap, we tend to see more breathiness. So as you get better closure, CPP or cepstral peak prominence it reflects that treatment change in vocal fold vibration.
And, to ask a little bit more on that, I mean, we realize people don't have a lot of acoustic measures. I think the literature tells you what they find. And, what they find is that you decrease breathiness, you improve loudness, you reduce the effort that somebody has to put forward, post PhoRTE. And quality of life improves when you ask somebody those questions with regard to their voice. But here's a tough question for you guys, because I got to be a little tough a little bit. And I get the same, issue. What about the placebo effect? If we put something into people's hands, whether it's an EMST device or, a nice clinician that's working with you, how do you know that these perceptual scales just aren't improving because people feel good and empowered by what you're doing?
I think our first study back in 2014 can speak to this, and that is that we had a no treatment group. So we had a group of people that spent the same amount of time. And what was fascinating to us, Chris, it was amazing. In just a short 4 weeks, people actually demonstrated a decline in their patient quality of life and their voice quality of life measures. And, if you look at other studies, you can also, placebo, of course, plays a piece of a role. You're actually empowering people to think about their voice, and that's a great thing. But if you look at dosing studies with older adults, what we know is that older adults talk less. We know actually from some good studies out there that there is some relationship between decline in vocal power, vocal loudness, increased vocal effort, reduced vocal endurance, and less vocal load. Right. So the effect of therapy is literally increasing the amount of time that they talk. If that's the placebo, great, because they are coming back and saying, I feel less vocal effort. My friends say they can hear me. I'm not embarrassed about my voice. And I think that's the winning ticket.
Wow. And I do the ticket of the improvements in quality and the loudness with, what I think folks will learn from your courses is a relatively straightforward technique for people to learn. They're able to carry it over. at home. And I thought, Erin and Edie, that work that you were talking about on the chronic cough, the cough. Can you talk a little bit more about that? Because there was a question too about lubrications, and whether you feel comfortable commenting on what's good for the vocal folds. Should we be drinking tea? Should we be sucking on a cough drop? Should we be drinking more water? So maybe in that conversation briefly, if you could talk about those two things, I'd appreciate it.
Sure. And, in thinking about both voice and chronic cough, we really do need to think about lubrication of the mucosa of the upper airway. I think that we know that this population may have some issues with lubrication, given that many may be on medications for other conditions. So polypharmacy can be an issue where we have less lubrication, more drying due to effects of these medications. And so, of course, in that case, you're not going to tell anybody to stop taking a medication. You'll advise them to consult with the prescribing physician or prescribing provider. But you can certainly recommend topical hydration with like a nebulizer. You could also consider giving recommendations for non-caffeinated fluids. Again, though, considering this population, older adults, they may be fluid restricted. So make sure that you are aware of their intake of hydration and what they're allowed to have. And they also may have some dryness just from loss of airflow, right? If they have a gap and they're going through their air quite quickly, then they're constantly retanking, and we do that through the mouth, usually in quick conversation. So just the act of talking is drying their vocal folds potentially in somebody who's taking more frequent breaths. So nebulizing is not a bad idea. When the tissue is healthier, when it's well hydrated, it vibrates better. It's easier, right? And we know in this population, tissue becomes stiffer. There's more collagen, both in the lungs and in the mucosa. So it's harder to move air. It's harder to vibrate the vocal folds. Anything we can do to make them to improve in their vibratory behavior is great. But with regards to the relationship between cough and voice problems, of course, cough is a symptom that comes about from a multitude of problems, etiologies. But when we're thinking about it, we're thinking that other things have already been excluded, right? They don't have an aspiration, an issue with aspiration. They don't have an aspiration pneumonia. They don't have these types of causes of cough. But we see that whenever they talk, they have, and is it a cough? A throat clear, it's a laryngeal behavior that's expectorating, trying to expectorate something, or sometimes I think it's psychological in relation to perceiving some voice quality changes. So they're trying to do something to clear something that's causing this roughness. That it would be obviously better to get better vocal fold vibration rather than throat clear, because there's usually nothing there to clear off the vocal folds. And so one of the recommendations is don't do that, right? Because you probably don't need to. People have looked at your voice box, looked at your larynx, and there's no secretions. You're not aspirating. So it's not serving you physiologically. And then once they've reduced the coughing from just not doing it as much, there tends to be some improvement because they're not constantly irritating the tissue. But in some patients, you need to re-coordinate respiration and phonation. They're not generating enough subglottal pressure, maintaining adequate airflow, and so they have to do it laryngally. And that laryngeal posturing to help generate subglottal pressure causes their need to cough. There's irritation.
Yeah, and you refer to it, Edie, as the dance between phonation and respiration. I always use the faucet, as you have a valve and you're going to be managing your flow rate with the amount of subglottal pressure that you generate in respiration. And, we could talk about this all day in terms of that dance between phonation and respiration, and the dance between laryngeal valving capability and swallow function, and a voluntary cough production. So folks, there's a lot tied up in here that Dr. Ziegler and Dr. Hapner are talking about. So, people asked, have you tested this in Parkinson's disease? Have you tested this in COPD? And again, I want to remind people, and Edie, chime in here. There's a limit of time of how much you can apply as a scholar these techniques across multiple populations. So one, we ask you, test it on your patient. You got to create your own pilots with your clients. You got to understand the mechanisms of PhoRTE or RMT. And then we ask you to test it, report on it, do a poster on it, right? So Edie, when we're thinking about that, what are some things you'd like to see people apply PhoRTE to? You can't do it all. You're the developer. Where do we want the clinicians to do?
And actually, to be honest with you, we don't want to do it all because we really, lots of minds bringing in lots of new creative ideas and seeing maybe populations we don't see. So we always ask the people that we train to, tell it. We're happy to help you design a study if you don't feel comfortable doing it. But if you do, please do it. We have not tested it on people with Parkinson's disease. One, because of time. Two, there's some great therapies already out there that have well tested on Parkinson's disease. But if somebody has that inkling to do it, it's a question we get asked all the time. I would encourage you to do it. And Erin and I are always here to kind of give you a little insight. Now we have to remember, Parkinson's isn't just aging voice. There's a lot of other components that go along. So, the recalibration is not part of PhoRTE, and that's a big piece with Parkinson's disease. But if I can just speak to COPD very quickly, COPD is almost endemic in the aging population, right? So when we get older, for those of you who are nice and young, I hate to tell you, but everything gets older. So there's not only laryngeal decline, there's respiratory decline. And I think Erin, touched on that briefly, but COPD is a finding in a great percentage of older adults. It does not preclude you from doing PhoRTE. We have studied to see if people feel less dyspnea with PhoRTE, but to me, that would be a great thing to do. And I actually think we're still looking at this whole idea of patients who come in and they don't complain about their voice, but they complain about a chronic cough. And Erin talked about one arm of this. I think the other arm that we've spent a lot of time talking about, we've talked to Dr. Hoffman about this a lot too, and that is pulmonary toilet. And isn't that like my favorite term? Erin knew I was going to have to get that in. So, but is doing exuberant voicing with increased respiratory flow actually helping you start to clear your airways and improving your pulmonary toilet? So if somebody is interested in looking at respiratory function changes with the use of PhoRTE, we would be thrilled to see something. Anything else, Erin, that I'm forgetting?
Well, I do want to, it's on the chat. And so I'm happy to just briefly mention that we have a study going on right now. It's a single subject design study. So each person acts as their own control, where we are looking at IMST and PhoRTE sequentially with counterbalancing the order. And what we're seeing is really phenomenal. All outcomes, the whole battery. We haven't looked at the larynx again, but everything else, clinician perceptual, aerodynamic, acoustic, patient perceptual, they all improved in the same way. And it's a very clean story, at least right now with the patients that have been recruited. And I think it's because, in many of our therapies, we focus on the exhalatory phase, but the exhalatory phase in voice is very dependent on how much air you bring in. And conversation moves quickly. And as we age, it gets harder to move in a lot of air quickly. Our system is just not as compliant. It's stiffer, and it just takes more time to draw in more air. So doing IMST, I think we're going to find is going to be a really important piece for anybody who has a condition that causes weakness with inhalation.
So well said. And, I think you touched on, and I know colleagues is getting close to the 6:30 mark, but it's just so well said because lung compliance changes. And that's with Parkinson's, that's with aging, that's with many different conditions. And Erin is completely correct. When that compliance is decreased, it's harder to inspire. So the IMT, look forward to those results will help with that. It's, it's basically retraining the muscles to be able to stretch a stiff system. Remember, the lungs don't move without muscles. And so I think one of the things we want to touch upon is everything we're talking about is skeletal muscle, whether it's the diaphragm, the abdominal muscles, the oral facial muscles, as well as the laryngeal muscles. And as Dr. Hapner pointed out, those respond to load, those respond to exercise. And that's what, we're all been studying for such a long time in our careers. So I'm going to end with one important question, two actually. One is, Erin or Edie, type in if you've got a social media account, if people can follow you on Instagram, please throw that into the chat because people are wondering. And number two, will you be in New Orleans at ASHA? And what are you presenting on? And where can people find you?
I hope you're there, Edie.
Well, I'm the co-chair.
I hope you're there.
Not missing, no. So we are not presenting on PhoRTE at ASHA this year, but Erin and I are each presenting on a bunch of other things. I am excited about a study, just in the same vein that we're talking about, that we are looking at glottal gap size and other parameters and the physician's decision-making paradigm, with the goal, ultimately, we're using things like Image J to measure glottal gap. We're looking at physicians' perception of glottal gap. Right. Are they sending to therapy? Are they sending to augmentation? There is, from a study we did earlier, there is no definitive paradigm for making a decision. Do I go to therapy? Or do I send them for augmentation? And what we're also hoping to encourage through this paradigm is the partnership, that it is more than just looking at a glottal gap. It's more than just being laryngocentric. It's respiration, it's cognition, right. It's aphasia, it's everything. And that the speech pathologist and the otolaryngologists need to partner for best outcomes. So I'm real excited about this study and where it's going.
Well, I'll tell you what, at 6:29, I can tell you that knowing Gail Wiley, I would think that she would love to host you guys in a seminar. We look forward to the asynchronous content that's coming soon. You've got some websites there to find you. Edie and Erin, we hope you come over and visit our table for Aspire that Gail is hosting. And thanks to you, Kay, for being here. Thanks for the 210 people that showed up tonight. We're 6:30 on the dot. Colleagues, so good to see you. Thanks so much for, as I will say, Erin, an exuberant seminar.
Thank you.
Thank you.
Good night, everyone. Good night.